Thank you, Florence, and excellent job in arranging this excellent program and getting a group of excellent people around who are enthusiastic, who are great. I see the enthusiasm. Nobody's sleeping. Everybody's paying attention. It's great. It's absolutely marvelous. So I'm gonna have some technical stuff in my presentation. So if you get bored, just let me know. We'll skip some slides. I'm going to start with what stroke is and why is it important. Stroke is the 4th leading cause of death in the United States and is the leading cause of disability. There are approximately 800,000 strokes every year and 200,000 deaths every year from stroke. There are modifiable risk factors that we can control and manage, which include diabetes, hypertension, atrial fibrillation, substance abuse, and smoking. And then there are non-modifiable risk factors that include age, gender, race, family history, our genes, which we can't do much about. So why is it important? Of those who survive, most frequently presenting problem is hemiplegia or weakness. During the acute period, there is a high incidence of associated other neurological problems such as visual defects, visual problems, coordination problems, facial weakness, swallowing problems. And the one medical important concern is the incidence of comorbidities that may affect management of stroke patients in the hospital and then in the rehab. Before we go into different types of stroke, what I want to do is, I want to show a clip of the ER show. This is not exactly what happens every day in JFK, but it's very close to how our stroke team works.
Can I call you right back? 5 minutes? Okay, great. Thanks so much. Bye. Somebody help me.
Well, there's no evidence of hemorrhage, so it's probably a clot.
It's too late for TPA?
Can cause brain bleed if it's done after 3 hours. As our kids saw her a few hours ago. At a rig ride, ER assessment. It's too close to take a chance.
Well, what are other options?
I hope that collateral flow can develop. Get her into physical therapy. With a major stroke like this, the chances of a meaningful recovery aren't good. The only other option is the Mercy.
For what?
It's a catheter retrieval system. Takes you into the brain through an artery. Allows you to corkscrew the clot out.
And it reverses the stroke completely?
It's not without risks.
The stroke affected the language center of her brain, so she can see and hear, but she cannot communicate. Do you want us to go ahead with the procedure?
Say yes.
What happens if we don't do it?
Well, her heart condition is treated, but she won't improve neurologically.
But she won't die.
No, Dan, listen to what he's saying. This other thing might fix me. Please, this once, hear me.
Oh my God. Ellie?
Give consent. Please.
Okay.
Fluoro on.
Torquing clockwise.
Injecting?
Cross your fingers. 1, 2, 3.
10 cc's
4.
in.
Think you got it?
Pulling back. Got it.
Beautiful.
Fully recanulized. No fragments in the distal branches. Wide open. Wake up, Ellie.
Okay, let's set her up. Want to try and say something?
Thank you.
So, of course, this is a TV show. There is dramatization. That's what we are hoping to achieve, to get the best possible outcomes. And we are there to some degrees, and to others, we are still not there yet. We try our best, and we try to achieve that as our best possible outcomes. There are different types of stroke. I'm going to go back to some dry subject here. The ischemic strokes are the one that happens because the blood clot blocks the blood vessel and there is no perfusion to the brain going on. Then there is a cerebral thrombosis, which is a plaque buildup and results in the same thing. It causes the blood vessels to get blocked off. And cerebral embolism can cause the same ischemic kind of a stroke or clotting kind of a stroke, where a blood clot from elsewhere can go inside the blood vessel and block the blood vessel that supplies that part of the brain. So different kinds of strokes. What is the hemorrhagic kind of stroke? It's lesser common than the ischemic stroke. It may be more deadly. If the patient does survive, there may be a better recovery of function in these kinds of strokes. Why is that? The blood supply to the brain is stopped in the ischemic stroke, but the hemorrhagic stroke causes pressure, which displaces the brain tissue, does not necessarily damage and irreparably damage the brain tissue. So that's why there is local compression, but not necessarily irreversible damage to the brain. Hemorrhages can happen in different forms. There can be a bleeding kind of a stroke, which we call a subarachnoid hemorrhage, which goes in the brain tissues, the planes of different brain tissues, and around the blood vessels and on the surface of the brain. Or it could be in the brain tissue itself, which is called the cerebral hemorrhage. The causes for subarachnoid kind of hemorrhages are usually the aneurysm that pop. When the aneurysm pops, it goes around the whole substance of the brain and causes a diffuse kind of a hemorrhage as compared to bleeding kind of a hemorrhage inside the brain tissue, which we call intracerebral hemorrhage, which is aggravated by hypertension. So what is the difference between the right hemispheric stroke? The right hemispheric stroke, or the right side of the brain stroke, controls the left side of the body. And it affects not only the strength and the function, the sensory function, which is the numbness, not only causes that, but it also can cause problems with analytical tasks and perceptual tasks. The left hemispheric stroke, the left side of the brain strokes, controls the movement of the right side of the body, as well as our speech and language. So ability to understand, to comprehend, and to be able to express is sometimes affected when you have a left brain stroke, especially if you are a right-handed person. This is how the strokes look like on MRIs. They're usually bright. They stand out on MRIs very, very much. And in this situation, you're seeing a right-sided stroke on this patient. There are other kinds of stroke, the back of the brain strokes. Cerebellar stroke is one of them. Cerebellar stroke controls our reflexes and much of our balance and coordination. Therefore, a stroke affecting the back part or the cerebellar part can affect the coordination and balance. The brainstem stroke is an area of the brain that controls all our involuntary or basic automatic functions of the body. And those are life support functions, such as the ability of eye movements, hearing, speech, swallowing, even the respiratory cycle and the cardiac cycle is controlled by the area called the brainstem, which is in the back part of the brain, just above where the spinal cord starts. So as the brain condenses itself into a smaller portion to become spinal cord. That's where the brainstem is, and that's considered a back part of the brain also. What are the symptoms that we should be aware of? The strokes can be sudden. They're usually painless unless they are the hemorrhagic or the bleeding kind of stroke that could be accompanied by a very severe headache. There is unilateral weakness, unilateral numbness, slurring of speech, inability to talk, inability to comprehend, loss of vision in one eye or the other, loss of vision in one half of the visual field. So both eyes are affected and you just can't see on the right side or you just can't see on the left side. Imbalance, coordination problems, vertigo, nausea, or vomiting with accompanying headaches. Headache is usually a hallmark, as I said before, of a bleeding kind of a stroke, not the ischemic kind or where the EMTs or EMS assess three things. The speech, so they would ask a question from what is suspected as stroke victim. If the speech is slurred, or you're unable to get your words out, or unable to understand what a person is saying, you suspect stroke. Second thing they assess is face, whether the face is symmetrical or is like drooping one way or another. That's the second thing the EMS assesses. And then the third thing to assess is the weakness of one limb or the other limb. So this is called the Cincinnati stroke scale, and Florence is showing you the chart that she has been trying to emphasize on. So some basic requirements for looking at these three things. Again, speech, face, and limb weakness. If you get one of these three things, there is a possibility that this is a stroke. If you get two out of those three, there's a very high probability that you have a stroke. If you got 3 out of 3, it's almost certain that the person that you're dealing with is suffering from a stroke. So this is an easy to do scale. This is what the EMS evaluates you on. And what you need to do if you see a loved one or anyone that that you have assessed in a quick fashion, what you need to do is to make sure that you call EMS and 911 and get that person quickly to the closest designated stroke center. So what I wanted to show you what happens at the blood vessel level. What happens is that there is an endothelial damage to the blood vessel, and then the platelets, or the third component of the blood, there's red blood cells, white blood cells, and then there are platelets, they get attracted to it. And the circulating lipids, which is the cholesterol, builds up a plaque or thickening of the vessel wall. Once that vessel wall thickens, there is usually smooth muscle cells that proliferate under that layer. And that causes a nidus, or a place where the platelets can get attracted to, they can adhere to, and cause a plaque itself. So this is like a cross-section of a blood vessel where this process is shown in a cartoon-like fashion, where there is a formation of a thrombus. And thrombus is this thing that we fear the most. It can dislodge itself and cause what we call an embolus. Embolus is when it goes further upstream and blocks the blood vessel and supply to the brain tissue, and therefore deprive it of the oxygen. And there is always a saving grace, because there is this deprivation of the blood supply to that part of the brain where the thrombus is not letting the blood flow go. But then there is this collateral area where the blood can come around from other blood vessels and save it for a little while, give it enough time for us to be able to work immediately. If the collaterals are good, then the brain may survive for a few hours after the event, but it is key that the patient gets to the hospital as quickly as possible. For whatever knowledge, medical information we have right now, if we are able to open up the blood vessel fast, we can get better results. So this just shows, again, the same concept, that there is a blocked up blood vessel. and then there is an area of developing stroke or infarction in the middle of that part of the brain. But then there are other blood vessels that may help to keep that part of the brain going for some period of time. It's very important that this is addressed in a fast fashion. Sometimes what we see is that there is a small stroke which leads to a bigger stroke. This is a real CAT scan which shows how a smaller stroke to start with has converted itself into a bigger stroke and converted into these bright spots where the bleeding in the brain, right dead in the center of the brain, has happened. And that's where neurocritical care units are important. All comprehensive stroke centers, whether in New Jersey or elsewhere in the United States, will be required starting June or July to have neurocritical care centers or neurocritical care units. That is a specific kind of a critical care unit that is required to be either a part of the medical ICU or a surgical ICU. And this is what JFK has and some of the bigger tertiary care centers have. It's a very important disease. It's just not for men. Twice as many women die from stroke than from breast cancer. 1/3 of the strokes occur in women who are under the age of 65. 100,000 young and middle-aged women will suffer stroke in 2001. That is from American Heart Directive for the new century. They gave a big policy statement saying, this is not your grandmother's disease. Please take care of yourself. Please take care of yourself. You need to eat healthy, watch what you are doing, exercise, and they introduced the term called lifestyle modification, that you need to modify the way we go on our daily routine basis, where we ignore exercise, we ignore time for ourselves, we are stressed about stuff, but we ignore time for ourselves. So this was a directive and a kind of a policy issue that they thought would be a very important direction for the new century for women's health issues. African American women have the highest rate of stroke prevalence among the 3 major ethnic groups, including Caucasians and Hispanics. And there is an area called the stroke belt, and you'll be surprised to know that very unexpectedly, the stroke belt comprises an area that goes all the way from Georgia to Oklahoma in that southern belt area. And the stroke incidence is especially very, very high. But the Newark is the only place in the United States that goes with the same stroke rates as the southern belt itself. So a very important issue. What is a TIA, transient ischemic attack? This is a neurological event with the signs and symptoms of a stroke, but it goes away within a short period of time. TIAs typically last anywhere from 2 minutes to 30 minutes and can produce problems which were the similar list of problems that we talked about, including visual problems, dizziness, weakness, or trouble speaking. If not treated, there is a high risk of having a major stroke in the near future. So this is a perfect warning. It's a warning that there is an event to come, so that it needs to be taken very, very seriously. If the event, these symptoms resolve, please still treat it like as if you had a stroke and come immediately to the emergency nearest stroke center. So what are the risk factors for stroke? Going back to them, the non-modifiable ones are the age, or gender, race, genetic predisposition, but the modifiable ones, that's where we need to focus on. Hypertension, smoking, hyperlipidemia, diabetes, obesity, and drugs. I'm going to go one by one. Age, the chances of having a stroke go up with increasing age. But remember that even though 2/3 of strokes happen to people over age of 65, it can happen in a younger age. Just given the sheer number of strokes that happen, you can imagine how many strokes are still happening at or below the age of 55. Genders. The male have a slightly higher stroke risk than the females. But because women in the United States live longer than men, more stroke survivors over the age of 65 are actually women. Race. African Americans have a higher stroke risk than most other racial groups. Family history of stroke or TIA risk is higher with people who have a family history of stroke or TIA, especially if their patients, aunts, uncles, brothers, sisters were younger, then you have a chance of having a stroke when you're younger. Personal history of diabetes. Persons who have history of diabetes have a higher risk of stroke. This may be due to circulation problems that the diabetes causes. So again, the modifiable stroke risk factors: high blood pressure, hypertension puts stress on the blood vessels all the time and can lead to strokes from blood clots or hemorrhages. So blood pressure is not bad when you're having a headache. It's bad all the time because it's putting a stress on your blood vessels. Having high blood pressure or hypertension increases stroke risk by 4 to 6 times, a big amount. It is the single most important controllable stroke risk factor. It is a common condition and affects approximately 50 million Americans, or 1/3 of the adult population. Atrial fibrillation. About 15% of all patients, all people who have stroke, have a heart disease called atrial fibrillation. This is a condition in which the upper chamber of the heart, which is only the function to pump the blood to the lower chamber, which pumps the blood all over, the upper chamber of the heart, instead of pumping, it starts to quiver. So it's not effectively pumping. It doesn't cause any problems with the circulation as such. The heart is able to overcome that. But what it does is that it causes that stagnant area of pooled blood where the blood clots can form. And once the blood clots are formed in the heart, they can go up and cause stroke-like symptoms. Among people ages of 50 to 59, atrial fibrillation is linked to 6.7% of all strokes. By the ages of 80 to 89, atrial fibrillation is responsible for over 1/3 of all strokes. So it becomes even a bigger problem as you advance with age. So look at all the other causes that causes stroke, and atrial fibrillation is half of it. So a big problem with strokes that originate from the heart. And a big problem as you grow older, the risk of stroke goes up if you have atrial fibrillation. The red lines give you the risk of stroke due to atrial fibrillation, and the bottom numbers are the age ranges. So 50 to 59, 60 to 69, 70 to 79, 80 to 89, you can see how high the risk of stroke goes when you have atrial fibrillation. If you have heart disease or high cholesterol, that also directly and indirectly increases the risk of stroke. It not only does it clog the blood vessels in the heart, it clogs the blood vessels in the brain. High levels of cholesterol in the bloodstream can lead to the buildup of plaque inside the vessels, the arteries that I showed you the picture. Then another important factor, very important and very commonly ignored, is the sleep apnea, the sleep problems. A lot of people snore. A lot of people feel tired during the daytime. What they don't recognize is that they are tired because they're not getting good sleep because they are snoring. Not only are they not letting their spouse sleep, but they can't sleep themselves either because they're constantly waking up from that snoring problem. And now the sleep apnea has been known and linked to the risk of strokes. So if this is a problem for you, please get a sleep study, a sleep evaluation. All big comprehensive neurological centers have sleep doctors. JFK has an excellent sleep lab, excellent sleep doctors, and we need to make use of this because the longer the time goes by, just like blood pressure, the longer the time goes by that you've been snoring, not sleeping properly at night, and having sleep problems and sleep apnea, the larger the risk for you to have a stroke will become. We talked a little bit about family history of stroke or TIA, that applies to a personal history of stroke or TIA. If you've had a TIA in the past, you're at a higher risk of having a stroke, and the same applies if you've had a stroke in the past. Smoking. Smoking doubles the stroke risk. Smoking damages blood vessels, speeds up the clogging of arteries by the deposits, raises blood pressure. Every puff of smoke, think about it, every puff of smoke, when you feel the rush going into the brain, for whoever smokes here, I used to smoke. I quit long time ago, but the rush that you feel of, like that's a rush because your blood pressure increases very, very transiently. And as that transient blood pressure increase happens, it damages the blood vessel. Every puff of smoke damages the blood vessels. Alcohol, I'm not going to tell you to start drinking if you don't drink, but it's supposed to, according to American Heart Association, in moderation, when you have a 1 or 2 drinks a day for 3 days or 4 days, according to American Heart Association, it's actually preventative, especially the red wine. But if you drink too excessively, it can really hurt you. And the other problem is that those people who have dependencies or who become dependent on alcohol, that may be a dangerous thing. So if you do too much of anything, it may be bad for you. How do we diagnose how do we diagnose strokes? We as physicians who treat strokes, and nurses and healthcare providers and stroke caregivers, we rely on history a lot. Time of onset, when did that stroke started, is very, very important, because almost all of our acute stroke treatments are going to depend on how many hours has it been since the stroke started. Other medical problems are important. Examination, neurological, cardiac, carotid examination, that's important. Imaging is important. Computerized tomography, which is the CAT scan of the head, or MRIs are important. These are the tools that we use. How do we manage acutely? We make sure that the ABCs, the airway, breathing, and circulation is taken control of. We do a quick history, a quick neurological examination. We do rapid blood draws in the emergency room. We do an immediate EKG and CT scan of the head without contrast. Believe it or not, all of this is done within 20 to 30 minutes of a patient showing up in the ER. We have timelines that we have to follow, and we follow them very, very strictly. What happens to the function of a person who suffered a stroke? It deteriorates rapidly, and in that acute phase, it just goes down. You can't move that arm. But then it starts to slowly recover and come back. And what is very important is that there are some other effects that may happen with stroke also. There could be emotional liability, there could be perceptual effects, there could be a difficulty of planning, carrying out simple tasks, there could be loss of awareness, difficulty with swallowing, there can be difficulty with putting words together or understanding the speech. So all these problems may come along with the more obvious problem of a weakness, for example, or visual loss. What are the risk reduction things that we try to achieve during the stroke recovery, and even to prevent strokes from happening? Lifestyle changes are important. We think aspirin is good, but if you haven't had a TIA or you don't have heart disease risk factors, don't take aspirin. Don't take aspirin when you call 911 for anybody. That's very important. Just imagine if it is not a blockage kind of a stroke, if it is actually a bleeding kind of a stroke, how would you know it's a bleeding kind of a stroke? And you take aspirin, you just make it worse. So unlike heart attacks, where you know that no bleeding happens in heart, it's just that the arteries get clogged up, you can take an aspirin. But in stroke, you can't take an aspirin. What if it is a bleeding kind of a stroke? You're just going to make it worse and bigger. There are certain interventions we do, a lot of procedures we do. One of them is carotid stenting. We can open up any of the blood vessels, not only in the carotid here in the neck, but inside the head. We can do experimental We are a part of many different trials. We at least have 4 trials for intracerebral hemorrhage. We have 4 trials for stroke treatment. Actually, I wanted to show you another video clip here, which may be interesting. Something innovative and new JFK has been involved with. So it's hopefully going to be just a brief clip from the news from last year.
You're watching CBS 2 News in high definition.
Imagine surviving a massive stroke that doctors say would have killed most people.
CBS 2's Dr. Max Gomez shows us a new high-tech treatment that uses hypothermia to improve outcomes for stroke victims. Dr. Max?
Well, Christine, you know, we've all heard of people who nearly drown in icy water but survive because the cold temperature chills their brain and protects it from damage that comes from lack of oxygen. Now doctors are using that same idea to chill stroke victims on purpose. It saved this woman's life and her brain. Maria Isalis Guzman has been doing intensive physical therapy for 3 months now, learning to walk again. It's hard work, but Maria does it gladly, considering what almost happened to her.
I shouldn't be here right now. I should have been, 3 months ago, I should have been in the ground.
Maria had ruptured a large aneurysm in her brain, causing a massive stroke.
She came to the emergency room seizing. Unconscious, seizing, in a comatose state.
Then things actually got worse. The blood spilled in her brain was extremely irritating, triggering a high fever, infection, and causing the brain to swell. Then the blood vessels in her head went into spasm.
One of our team members put it like she was trying to constantly die, and we were having a tough time bringing her back.
So what accounts for this amazing recovery? Doctors at JFK Medical Center in Edison, New Jersey decided to try controlled hypothermia, chilling Maria with cold water pads to bring her temperature down to just above 91 degrees Fahrenheit. They kept her there for several days, but then came an even trickier phase.
Most complication of hypothermia happens when you try to rewarm the patient. So it is controlled cooling and controlled rewarming.
Her doctors were amazed that she survived with just some partial paralysis on her right side, but they were stunned that her brain function is almost perfect.
My short-term memory is really bad, though. Like, I forgot your name right now.
Now, doctors say there's no question that the hypothermia controlled Maria's fever and lowered her brain metabolism enough to allow her to survive. This kind of hypothermia is already standard practice for heart attack victims in New York and may soon be for stroke victims as well. Maurice?
Thank you, Max.
So I just wanted to touch a little bit upon the strength of, another strength of development in advancement in stroke care and therapy. That's rehab. It's very, very important. Rehab is important at JFK and elsewhere for stroke victims because that gets you back. That really, really gets you back. You need those baby steps all over again to get back, train, work hard, and those who do, they do see the benefit of the rehabilitation. It's estimated that since 30% of the strokes happen in people under the age of 65, that the return of work can be amazing with good rehab. Planning for rehab is extremely important with the help of the speech therapist, with the physical therapist, occupational therapist, and every ancillary staff, nursing members, everybody that could be supportive for treatment planning. So it's a multidisciplinary approach. It's an approach that involves a big team of physicians, healthcare providers to try to do our best to provide the best cares. Thank you very much. I've put some resources here for you guys to look at if you want further education on any of these matters. I just touched upon everything very, very briefly. Thank you very much for your attention.